Auzubillahi Bismillahirrahmanirrahim. First, I would like to congratulate the scientific committee and the organizing committee chairs, Dr. Khurshid, President of Endocrinology Society, for setting up a great show today. Secondly, two great talks today by Dr. Aisha and Dr. Sadia Salman. Indeed, great things to have a dialogue and continue this, the need for and increase awareness. Building up this momentum today for the great scientific session that has been, prepared by the scientific committee chairs, we will continue the intense dialogue. My name is Dr. Jahanzeb Kamal. I am Director Medical Affairs, Clinical Trials for Getz Pharma. Today's topic is also very, very interesting. We have SAFE-PAK Trial, which was a randomized controlled trial, and this is the first grand show where we're going to disseminate this data. So to start off today's session, first I will invite the chairs of today's meeting in the order. I'll request Professor Zaman Sheikh to please take the chair here. Dr. Zaman does not require any introduction. Dr. Professor Khurshid, would you please join us here as well? Thank you very much, sir. And Dr. Professor Hafizullah, sir, please join us. Thank you very much, honorable chairs, for today's session. Now we're going to commensurate this session today. It's the first time that local data through randomized controlled trial that has been generated for a newer product that has been introduced in Pakistan. And serious great efforts have been done. Just to showcase here, the trial sites were all over Pakistan. We had investigators, honored investigators joined us this great clinical trial. The journey started around 2.5 years ago from today. It was a pre-COVID era. And the first meeting is just a glimpse of the first meeting that we did was back in February, first week of February 2019. And I'm very proud to say that today we are able to present this data, and it's a local Pakistani population data that is now available with us, and it will be disseminated to you in today's session. Now I'll request the principal investigator, do not require any introduction, to please take this place and share your valuable information and data. Thank you, Professor Aamir. Thank you.
Bismillah ar-Rahman ar-Rahim. Thank you, Jahanzeb, for a kind introduction. Thank you, PES, for giving us opportunity to showcase one of, I think, very important data which I would like to share with everyone here. Thank you for the scientific committee to give us opportunity for showcasing our data. This slide might look very familiar and kind of boring as well. Now what we keep on talking is the high prevalence of diabetes across the world. But what I would like you to concentrate on Southeast Asia and the MENA region. This is us. This is where we are placed. So if you look all around, these are the two areas which needs attention. There's a lot of diabetes around. Pakistan has been put in MENA region simply because of political reasons, because we don't want to be with India, and the IDF has put us in MENA, fair enough, but high prevalence of diabetes. In Southeast Asia, who are people like us? Sri Lanka, Bangladesh, India for that matter, high prevalence. So On the face of it, this slide looks quite familiar, boring. We've done it so many times. What is important is that as of 2015, there are estimated 1.8 billion Muslims around, and most of them reside in Asia and Middle East Africa. So I've told you that the two areas which are of high intensity in diabetes, and then I'm telling you that these are the areas where a lot of Muslims live. So keep that in mind as we go along. What about Pakistan? Back in 2010, we had a data which showed that our prevalence is around 7%, and I'll leave it here, and I won't touch the India and Bangladesh and Sri Lanka, but this was our data way back in early 2000. We knew this was underestimate, and we did a survey, and then we found new figures, and now we know that there are around 16.9% prevalence in diabetes, which means around 19 million. And Dr. Bassett told us yesterday that these figures are going to go to around 33 million in the new atlas. So we are living in an area which has got a lot of diabetes. So we've got a lot of work to catch up. This was a survey which we did, and based off our survey and then Professor Bassett's survey, the prevalence figure have gone up. So that's the first part of it. 1/3 of diabetic patients have a CV disease. There are cardiologists around. Professor Hafiz is here. So that's another worry. And it doesn't finish here. What's important is people with diabetes would have a cardiovascular disease as they develop diabetes, but they may have issues related to cardiovascular even before the diagnosis of diabetes. So the problem is even bigger before the diagnosis of diabetes. What to talk of diabetes? It's even before there's a lot of cardiovascular involvement. We did another sub-analysis of our own study, which is published in Cardiovascular Endocrinology and Metabolism. And what we showed there is that even if you are not overweight, even if you are normal weight, the risk of diabetes is still there. And the risk of coronary artery disease is still there, even if you're not diabetic, even if you're diabetic and not overweight. So we have got such a diverse problems going on that we need to look critically at every part of it. And I would say here, though I'm talking about a drug here, but I would seriously say we need to really, really consider prevention program and take it real serious. And I'm glad that Pakistan Endocrine Society start to kick off the session with the prevention program. So there's a lot of problems. The other problem is that if there's no diabetes, above 60 years, you can live as much as, what is destined for you. But what we know now is that if you've got diabetes, you've got a shorter life after 60 years. And if you've got diabetes and CV disease, you are talking about a negative 1 decade. That's major. That's major. A country where we are struggling to increase the life expectancy, if you've got so much diabetes, 1/3 of them have got cardiovascular disease. What will you get? It's very difficult. And I think no government can struggle and can solve this problem unless we own and take action on this. The problem doesn't finish here. Abbas is not here. This was a study, Cardiff study. Abbas did, and we were part of it. What it showed was that most of the cardiovascular risk factors like dyslipidemia, hypertension, obesity, and glucose intolerance coexist in type 2 diabetes, which increases the risk of CVD, and this is at the time of diagnosis of diabetes. These were all newly diagnosed. They've already got all these risks. We've done the national study. Abbas was the lead here, and this is already published data. So we know that diabetes and CV risk factors, CV disease, the risk factors are common. And if you look at this part of the slide, the arterial stiffening, endothelial dysfunction, oxidative stress, platelet activation, all these, they are common in diabetes, but they're affecting cardiovascular disease. So we are looking at a disease, diabetes and cardiovascular, which needs attention and which has got a common pathophysiological outcomes which need addressing. Some renal physicians here, Kaisar Bhai is here, and what we know is that progression to heart and kidney disease because of different systems involvement, cardiac involvement and RAS system activation, we know that they are all affected and it can cause big havoc in terms of complications of diabetes as we go on. So much to talk about. So we all knew about this, but then we also knew that there was a trial called AMPEREG, which was done in around more than 7,000 patients. And this drug has really changed our practice and given us a hope that in the future we might get some benefit for our diabetics in terms of cardiovascular mortality, because this trial looked at CV morbidity mortality in patients with type 2 diabetes, what I've been talking about, and established cardiovascular disease. Exactly what I've been talking about. So the answer was still there. The answer is there. There's no secret. And we've got this a few years ago. And what it showed that empagliflozin reduces 3-point MACE by less than 14, CV death by less than 38, heart failure 35, and all-cause mortality by 32. A dream come true drug available to us now. What's the issue? The issue is that there are some side effects attached to it, as it will happen with most of the drugs. And the commonest is, of course, hypoglycemia. But the next common, which is usually kind of unusual, is urinary tract infection and genital infections. Remember, this was done in Western world. So we did our own study. We said, let's see what happens to our population. What is is there any asymptomatic urinary tract infection in Pakistani Muslim? We screened 745, and I'm glad to say that a lot of our colleagues who took part in it are sitting here actually. We published this in BMC Infectious Diseases only 2 months ago, and what we showed was there's asymptomatic urinary tract infection associated risk factors in Pakistani Muslim population. So this is no drug involved. We screened 745, and what did we find? We found 8% of diabetics who are asymptomatic. Remember, they are asymptomatic. They don't have symptoms of UTI. They're completely asymptomatic. They come for just a checkup. And we didn't took a urine DR. We took a culture, urine culture, and they were culture positive, completely asymptomatic, type 2 diabetics, walking into your clinic, asymptomatic. So, in Pakistani Muslim population, we've got a lot of asymptomatic UTI. We found also that female gender has got a higher prevalence. We found that 40 to 59 years is the age which we found in that cohort. And we also found that if they are diabetic and the A1C is more than 7, no surprise, they will have some infection. This was a sensitivity part, which is no different than what we find in non-diabetics. E. coli is the commonest one, and then the nalidixic acid and all these drugs which are sensitive. And we found ciprofloxacin, as most of us know who are in clinical practice, that it is resistant to ciprofloxacin. So we know now that there is a high prevalence of diabetes in the world. 1/4 of the world population is Muslim. High prevalence of diabetes in Pakistan, high prevalence of heart diseases in diabetics, even high CVD in pre-diabetics, we all know that. High prevalence of DM and heart disease, even in normal weight patients, we also know, and I've shown you the slides with the data. CV morbidity and mortality can be reduced by SGLT2 through AMPEREG, we've seen. And SGLT2 can cause UTI and fungal infection in diabetics. That was the AMPEREG. But Pakistani Muslim diabetics have asymptomatic UTI. We also found that out, and we've published that. And then we said, well, there's a wet and dry hygiene practice between European and Pakistan. And does the same prevalence, what was shown in a PAK trial, affects us? So hence we saw that we will study safety and efficacy of empagliflozin in Pakistani Muslim type 2 diabetic patients. So this is all the preamble which I've given you, that why we did that and how we progress. So this is the trial which we did from June 19, in fact recruited from June 19 to August 20. There were really tough times, but I'm not going to bore you with that. So this was all the key inclusion criteria: type 2 diabetic Muslim patients, because we think the wet hygiene practices might be the key of lower urinary tract infections, both genders, glycosylated between 7 and 10, BMI less than 45, and drug naive. So we had a screening, we had a randomization, and we had the projected numbers that we wanted to include in the usual care, about 170, and 170 in an intervention arm, which was empagliflozin. But what we are looking at? We are looking at our primary endpoint, which was urinary tract infection, hypoglycemic events, hypotension. That is something which is, again, unrecognized. And we wanted to see that because we live in an environment where there's a hot, humid environment. And maybe hypoglycemia is something we need to consider. So hypotension is, we looked at dehydration, fungal infection, and any other side effects. Our secondary endpoint was glycosylated hemoglobin. Was there any change? Fasting blood glucose. And we also looked at the quality of life. People have been talking about, Sadi has just spoken about the psychological aspects. So we looked at the quality of life part. This is our patient disposition chart, and this is quite extensive. I won't go into details of that, but what I would like you to see is the group A, which was intervention arm, in which we intervened with empagliflozin 10 and 25 milligram, and in group B was usual care. So in both these groups, the investigator had a liberty, if they found the A1C is not up to the target, to intervene and go ahead with the intervention, whatever they found necessary. There were follow-up at 6 weeks, at 12 weeks, and at 24 weeks. This was the follow-up for the whole project. If you look at the baseline characteristics, there were slightly more female in the EMPA arm. Age was almost the same. The BMI, there was slightly overweight in the EMPA group compared to the usual care group. And the duration of diabetes was, again, slightly more in EMPA group. So majority of participants of group A were females, obese, and had a longer duration of diabetes. So in a nutshell, we can say that in an EMPA arm, we ended up having slightly more severe patients compared to usual arm group. We also recorded the physical activity status because one would argue that whether the improvement what we saw was because of increase, because in a trial environment, you give them a lot of education regarding the drug, you give them a lot of education about the lifestyle. So all these were put into place. But if you look at the both arms, almost 80% of them, as would imagine in Pakistani diabetics, that they had a sedentary or not good physical activity. So nothing really to choose between the two arms. Comorbid condition, hypertension, dyslipidemia, obesity, this is a common cocktail. The risk factors, I've shown you in a Cardiff trial as well, that patient had at diagnosis all these risk factors. So all these were included. We had a lovely talk about NASH and NFLD last night by Professor Wasim. So all the risk factors were there, and they had some complications. What about the drugs? If you look at the drugs, as would happen, that metformin was a drug which was commonly used. Sulfonylurea was present in both arms, DPP-4 insulin, and they were also on antihypertensive and lipid-lowering agents and anticoagulant, as would happen in most of our diabetic patients. Heart rate was not much different, and we wanted to put it because These days, a lot of emphasis has been put on a heart rate, particularly if patient is on GLP. None of our patient was on GLP, but we recorded that. We didn't find any difference. And again, the baseline biochemical profile, nothing to choose between the two. They were almost matching both the groups. And same applies to other biochemical profile, nothing to choose between the two groups in terms of the biochemical profile. So what did we found? Remember, we had two outcomes, the safety and efficacy. What was the safety outcome on this trial? The group A was intervention arm, in which we had empagliflozin. Number of patient-reported adverse effect was 7.4% compared to group B, which was 15.8 and 16 patients. One adverse effect and two adverse effect. So there were patients who had one effect, there are same patient who had another side effect, one way or the other, the hypoglycemia or the hypotension episode. So again, we had slightly more in the control group or the usual care group. Hypoglycemia was reported 17.8% in the usual care. Remember, I said the physician was given the liberty to increase the dose if they want. So if you're not giving them empagliflozin, you can increase the dose of insulin, you can increase the dose of sulfonylurea, or you can increase the dose of DPP-4, whatever you may find necessary, because the target was we want to achieve a good A1C. So we saw the hypoglycemia more in usual care group compared to only 9 patients, which is about 13% in empagliflozin. Dehydration was no different. Hypotension, more in usual care. Positive urine cultures, there was 7.4% in EMPA. There was around 10%, 10 patients had positive urine culture. And that gives us an idea, and the study which you've done earlier, that there's an asymptomatic UTI anyway in diabetics. And that's what we are probably looking at, and maybe that is contributing here as well, in the EMPA arm as well. Fungal infection, we found more in usual care group, and we had to discontinue treatment in 2 patients in both arms. So these were our treatment-related adverse effects in this trial. So we had hypoglycemia, positive urine culture were more reported in the usual care group. 12 patients of a usual care group reported hypoglycemia, and they were all on metformin. Association of sulfonylurea and insulin with hypoglycemia was found insignificant. And we particularly looked for it because there were more hypoglycemia in the usual care arm group. And because they were not on EMPA, the physician must have increased the sulfonylurea or insulin for that matter, but we didn't find any significant statistically. Whereas in EMPA group, 6 patients who reported hypoglycemia. Fungal infections were reported very small number in participants. That might be because of education. You remember, when you intervene in patients and give them a lot of education regarding wet and dry hygiene, that was provided to these patients. And we saw very small number of patients having fungal infection in intervention arm. What about the secondary? Okay, it all looks very good. It all looks very nice that everything is hunky-dory with the safety part of it. But what about the outcomes, secondary part? So glycemic control, weight, blood pressure, and lipid profiles. What did we found? The glycemic level, look at the A1C. We had a reduction in A1C in both arms. So if you look at the group A, which was EMPA, A1C was reduced to 7.4, which was clinically and statistically significant. But it was also seen in the usual care group. Again, clinically and statistically, both significant. So we achieved the glycemic control in both the arms. What about the percentage of patients over time? So a second follow-up, if you look, A1C of less than 7, which we wanted to achieve, 41% of patients in EMPA group achieved A1C, only against 28% in the usual care. And when we follow up at 6 months, we saw 35% of patients in AMPA group achieving A1C, sustained achieve A1C at about 6 months, and then at about 31% in the usual care. What about the blood fasting blood glucose? That's another way of monitoring the control. 22% had a fasting between 100 and 120 in AMPA group compared to 20% in the usual care. And if you look at third follow-up, again, more numbers in AMPA compared to the usual group. They were clinically significant, but they were not statistically significant. What about the weight? That's another thing. We all know that most of our diabetics are overweight, if not obese. So that's a challenge, because whatever drug you give, you want to make sure at least they don't gain weight, because that's a negative part. So what happened to AMPA group? Our AMPA group has actually shown reduction, whereas if you look at the usual care group, they had actually remained stable or slightly gained weight. Again, in AMPA group, we had a reduction of 1.4 kilos of weight, and which was clinically and biochemically and statistically significant. What about the blood pressure? Again, another risk factor which we want to look at. So there was a reduction in the blood pressure in the AMPA arm of around 5 millimeter of mercury in the systolic blood pressure, and there was not much reduction in the usual care group. What about the lipid profile? We saw the lipid profile, and what we saw in the LDL, there was a drop in LDL of around 8 milligram per deciliter. It was more in a usual care group. And if you look at the HDL, there was an increase in HDL in patients, which was clinically and statistically significant in AMPA group. So we are getting a vibes that we are using a drug, intervening a drug, which is causing weight loss, which is giving us a good biochemical profile in terms of lipids. There's a slight drop of blood pressure as well. ALT, again, a reduction seen in both arms, and it was almost matched. It was much robust in the usual care, and it was significant in both, but more in the usual care group. We also made the quality of life outcomes. They were actually matching each other. They were superimposed on each, and we had scores on visit 1, visit 2, and visit 3, and we used a standardized performer, which is used for diabetics regarding the quality of life. So if you're giving somebody a new drug, whether they're happy with it or not. In this case, both the arms were happy. And one can argue that you are giving a lot of attention to your patient who is coming for a trial, and that would happen even in a usual care group. So a lot of satisfaction in terms of both arms. And these are the graphs related, and you can see they are actually matching in both arms. And maybe you can say that all the physicians who were treating, they were really looking after their patients very well. So in conclusion, ladies and gentlemen, what we found in SAFE-PAK trial was empagliflozin has proven as a safe drug of choice as compared to standard care in Pakistani Muslim population. Empagliflozin is effective as standard care, but it achieves glycemic control with weight loss. That is something over and above. So you are not achieving a control at the cost of a weight gain, which is not good in any of our diabetic patients. In addition, empagliflozin had a significant blood pressure lowering effect, specifically systolic blood pressure as compared to usual care. And with safety and efficacy, and I've told you the PAK trial, in Pakistani Muslim population, does it reflect on CV benefits too? I don't know. We haven't tested it. It's been tested in the West. Cardiologists are here. It's an open discussion. And whether we are giving added benefit to our patient by giving them the lesser morbidity and mortality in terms of cardiovascular, which we have seen. 1/3, and I think Hafiz Saab will bear me out, it's about 17% prevalence of cardiovascular disease in this part of the world. And it's about same person with diabetes. So we are a population which is a very high-risk population and a high cardiovascular. So are we giving any benefit? I don't know. I don't have an answer. We can just speculate. But we saw certainly it's a safe drug, not much infections that we saw, and good glycemic control with the weight loss. We have presented interim data in PSIM in Karachi. That was about more than a year ago. That was interim data in 2019. And then this was accepted in Diabetes UK, and we presented oral presentation to Diabetes UK Professional Conference 2021, only a few months ago. And it was also accepted in American Association of Clinical Endocrinology. We presented with an oral poster there. It was accepted. They're all published now. The abstracts are published. The paper is about to come in a clinical practice very soon. This was our final meeting, and this is not my work. This is work of all these worthy colleagues, and it is not possible without all these colleagues, Imtiaz, Ali Asghar, Saeed, Abbas, Faisal, Ibrar, Dr. Jamal Zafar, Umar, Irshad Kosu, Amna Riaz, and Tahir Ghaffar. I thank you very much for your patient listening.
Thank you very much, sir. Great data, great research, great outcomes. So a lot of unmet medical needs, a lot of issues that was already, not been researched here in Pakistan. I already have a couple of my own questions and received some few questions. Regarding weight loss, it's a great unmet medical need. So did you find any portion, higher BMI, more weight loss, or is it standard? How you feel about this now?
Thank you. We had a weight loss per se. Because we lost some of the patients, the BMI was reduced as well, but very marginally. But important part was that the BMI probably doesn't reflect. What reflects is the waist circumference. So that was something which was missing in our part, but the weight loss was definite, and that was definite in the AMPA group. So BMI was slight reduction. I don't think I've shown in the slides, but we've got a data showing that a slight reduction in BMI as well.
So the patient with higher BMI had more weight loss, or how did?
No, it worked out. I mean, the patients who lost weight, we didn't have much morbid obese patients.
All right.
So there was a slight loss of reduction in BMI, but weight loss was certainly there.
Right.
But it was a very small BMI change.
Okay, great. So another question. You had 2 periods of Ramadan.
Yeah.
And there were patients who were fasting as well.
Yes. Yeah.
You didn't have any slides here.
Yeah.
But what's your general feel about this? Because there's a lot of questions raised on use of empagliflozin in Ramadan related to dehydration and other stuff. So what's your
remember we started the trial in June 2019, and the next 2020 Ramadan came into that. The data was that the patients who fasted was small, so we couldn't really analyze. We looked into that, but we couldn't analyze that data. But we didn't have any signals of warning from patients who fasted but the number was smaller. So I can't comment on that, but the patients who fasted, they continued using empagliflozin, but the number was small.
Number was small.
Yes.
So generally you feel that,
it was there was no problem. We just have to switch the dosage, yeah.
So what's next? You have done UTI, side effects and other things. What about MACE? Want to?
Well,
that was the last, line there in your presentation.
I can't comment on that because that's something colleagues will tell us, and cardiologists will tell us that we need a long-term studies on a MACE point. You can't do it on this one.
All right. So we can take some questions from the floor. I already have. So we have raised some sir. Sir को please mic please sir को दें. Dr. Najam को mic दे दीजिए please. एक पीछे sir को please mic दे दीजिए. Dr. Shakil को. And then we have other questions here. We have a lot of questions. Great. I think it's a fantastic session where we have local data being disseminated, and local population is.
Thank you for giving me the chance to ask a question. Congratulations, Aamir, for your great work, and the GETS for supporting this. We had done a similar study, observational study, in AKU of over a 6 months period in second half of 1918, which is about to be published. It has been accepted as Pakistan Journal of Medical Sciences. It was an observational study only, and it involved both SGLT2, not just one. We found about UTI in about 8% of the patients. And the numbers that we were the first 100, so 8% UTI, and 3% had vulvovaginitis. So that's a figure that I just wanted to share. This is an observational study as against a controlled trial. The second thing is that in your study, surprisingly, we didn't find much of an UTI, neither a vulvovaginitis there. So that is it maybe related to the, but that is, your patients were only Muslim patients.
They're only Muslim
Yes,
patients.
and we had all non-Muslims and Muslims both together.
Yeah, yeah.
So, but majority of them were Muslims in that group anyway. So that is something that was surprising to me.
Yeah.
The second thing about the study that you did earlier with the asymptomatic UTI, you should have done urine DR as well simultaneously.
Oh, that was done. That was done.
Because asymptomatic UTI is usually not treated. And if the urine DR is not suggestive of UTI, culture is positive, it's all contamination.
Yeah, yeah. So this is what we found. We did the DR as well. It didn't show anything, and we found that it was around 8% in our study as well. Whether that's contamination, because obviously if you've got a lot of female patients, the advice to get the midstream sample, that's a challenge. That's a challenge to get that. But yes, that is one. That was actually one of the reviewer which commented on that, and we answered that this was the limitation that we had. But yes, there was 8%. In our patients, there was a UTI. It wasn't that there wasn't. And I think 2 or 3 of those we had to stop the drug. So there were patients in which we had to stop the drug because we found, and it was unethical to continue with the drug. So yes, we did find. But the number was more in the usual arm, to our surprise, compared to intervention. This is what the science is. Yeah.
Great. Dr. Khurshid, you had a question, and then sir ko piche dene, please.
Dr. Saab at the end.
Sir, please, you continue, and we'll pass on the mic, please. Up, sir.
Ji,
Ji, sir, please.
Dr. Aamir,
Please.
if you allow me, just one question.
Please.
If I take you to the last slide, the conclusion where you had, because what I understood from this presentation was hypoglycemia was statistically significant, weight loss was significant, and maybe effect on ALT and ALD might be because of weight loss or maybe a direct effect, we don't know. The question is regarding the safety profile, I did not see anything statistically significant in terms of safety data between this control group and the treatment group. Because in conclusion, if I take you to the slide, what impression I got there was it had better safety profile than the placebo arm.
Yeah.
Please, correct me. I might have missed something during your presentation, because my understanding of listening to you, statistically there was not any difference
Yeah.
in safety outcome.
Yes. That's correct. You're right. You're right on that. Do you mind
Sorry.
if we give them a chance? You're the chair. You can ask questions anytime. Please.
Professor Aamir, an excellent presentation. My question is, does this benefit extend to the other group of drugs in this, like DEPA? Does this extend to the other group? And the other question is it contradicted in underweight people?
Right. We didn't test any other drug in this. That was our shortcoming. We should have compared apple to apple, another drug of the same class, and see if it can be done in the other patients as well. As far as the weight is concerned, if somebody is catabolic and losing a lot of weight, and that's their concern, I would be very careful to give them this drug because they will remain catabolic. And if you're losing a lot of calories, you're going to reduce further weight. So I'll be very, worried to give somebody who's thin and lean this drug. I'll be worried. Unless you've got an indication, forced indication, to give them for a cardiovascular point of view.
Can we pass on the mic, please?
Mic at the back.
At the back.
Please
Sir.
speak in the mic.
Two quick questions. You said that the ablution practices between Muslims and non-Muslims were different. Was that an assumption or do you have an evidence for that? Secondly, you mentioned bacterial cultures. Did you actually count the bacterial counts in there? I mean, was it simple bacteriuria or was it an actual infection?
We wanted to look at the count. The report didn't give us the count. We wanted to look at that. And we actually thought that let's look at the count, but the lab report didn't give us that. The other part is the wet and dry hygiene practices. This is our theory. This is our theory. Because we didn't include it, because that was one of the question which was raised by the ethical board, that why you are excluding non-Muslim from this. And we said, we believe that the Muslims have a wet practices and they may clean differently compared to non-Muslims, and they actually raised the ethical, but we responded to that. Yes.
Please.
At the back, at the back.
Please, sir.
I am Akhtar Shireen from Khyber Medical University, Peshawar. First of all, I must congratulate you, sir, and your colleagues, and even Pakistan Endocrine Society for conducting a clinical trial, the randomized one, and again the collaborative research, because both are very close to my heart. And a few questions have been raised regarding the outcome or the outcome of the study, but I am more interested in a couple of methodology related points because these were not highlighted. Number one, what was the randomization procedure, because it was a collaborative study, multi-centered. So was a centralized randomization done? Sir, if
Yeah.
you can respond.
Yes, we had a one statistician responsible, and that was responsible for linking up all that. So any patient who is come, it was one-to-one randomization. I didn't put it purposely here, but it is all the methodology is written with us.
Because more people will follow you, because if we are conducting a randomized control trial, multi-centered, so every center has to phone call the centralized unit, because if you don't do that, then we will lose the randomization sequence for that. And
Yes.
was it a simple randomized? Was it a permuted block randomization?
It was simple randomization, and we had a human resource at each center who would link up with the center. So there was, in fact, a human resource at each center.
Because there's a one thing called center effect, and the small sample size of a center can make the difference in the statistical analysis as well, because we have to choose the appropriate statistics for that.
True.
So in such cases, the permuted block randomization is a better option for future,
Yeah.
because every center at any time the trial is closed, then uneven sample size can occur in a simple random procedure. And the second question is because the Professor Khurshid comment regarding the outcome, especially in these cases, if it was a non-inferiority trial, then you can apply different statistics, or equivalent trial, then different statistics can be applied. So even the statistical difference can be, because we call it spinning of data, when the appropriate statistics are not in. So first we have to establish what is it is a non-inferiority trial, the EMPA is not inferior to other drugs, then the different statistics will be applied. Thank you.
This was a non-inferiority.
Excuse me, my question is that as we know, type 2 diabetes, they have enough insulin. They have insulin resistant.
Dr. Asparagara, mic, please.
Ah,
Click. Thank you.
As we know, type 2 diabetic patients have enough insulin. They are insulin resistant. And if you combine empagliflozin with insulin or sulfonylurea groups, then you can't achieve the goal. You want to reduce the weight as well as protect the heart. So is it justifiable?
Right. AMPA can be used with insulin. AMPA can be used with the sulfonylurea. But the important part is when you use that, be careful, but there will be more hypoglycemia. And you've got to be ready for that. And you probably need a reduction in the dose of insulin or in the dose of sulfonylurea. The important part is that the mechanism, the hemostasis, what is achieved through AMPA is altogether different compared to what other drugs does. Because obviously this opens the tap to lose excess glucose in the urine. So the mechanism is altogether different for this kind of drug.
Next session is due. Sir, please.
Yeah. Just, Dr. Aamir, congratulations, very good conducted study. Just want to know, was there a difference between male and females in the incidence of the UTI there,
Yeah.
or?
Yeah, there was more infection in females and in the age group between 40 and 49. That was, so more in females, yes.
Okay, I have got few comments. Number one on the drug and trial, and number two on the speaker. Empagliflozin and overall SGLT2 inhibitor. It's a magic group of drug. Here purpose was not to show the efficacy because we know it is
That is safety,
efficacy
yes.
is okay.
Yes.
Purpose of this study was different, so it was successful in proving the difference. Now SGLT2 group is a magic group. It has got so many benefits. Number one, potency. Yes, it is potent, but glucose dependent action. Higher the glucose, more potent it is, like incretins. Although mechanism is different, but glucose dependent. And this is the reason this group of drugs is used in heart failure, even without diabetes. No diabetes, heart failure, you give this drug. And new study came regarding kidney disease. In chronic kidney disease, this disease is safe. Regress the progression of the kidney failure, even without diabetes. So glucose independent action. So efficacy with glucose dependent action. Number two, 95% of type 2 diabetic patients, they are obese. And this is good for obesity. More than 1 kilogram loss in few weeks. This is not a minor difference, actually. So this is another beauty of this drug. Then less hypoglycemia.
Yes.
We are afraid of hypoglycemia.
Hypoglycemia, true.
डॉक्टर साहब मेरे वालिद नींद में गए सही सलामत सुबह उनकी डेड बॉडी उठाई because of your drugs. Nocturnal hypoglycemia. So less hypoglycemia.
Patient is
another
fearful,
benefit
yes.
of this drug. Then safe on kidney and magic drug for cardiac failure. We have got 8 group of drugs available, oral drugs, in Pakistan for the treatment of type 2 diabetes. But these drugs are not equally good. Some are good for some patient, and they are dangerous for same patient. And best example is patient with congestive cardiac failure. If you give TZD, you may kill the patient. But if you give SGLT2 inhibitor, you may save the life. So every drug is not same for every diabetic patient, and one has to be very careful. Regarding hypertension, metabolic syndrome, close association of hypertension.
Ji.
So statistically significant difference of hypertension as well in overall SGLT2 group. So this is very
Thank you,
good
sir.
group of drug, and I congratulate
Thank you very
Gates
much. Thank you very much.
Company
Right.
for this local study.
Thank you very much.
And
Pleasure.
showing almost same result. As
Ji.
international.
At least we have local population data now. We have
And about the
confidence.
speaker,
Ji.
I congratulate you. I always enjoy your talk. you have got control on your emotions. Some speakers become emotional when they give
Dr.
some,
Zaman, you did try your best, by the way.
when they give some happy talk, they laugh themselves.
Right.
And they give some gloomy talk, it is appears that udas ho gaye hain khud bichare. But I congratulate you, got control over yourself, and you talk very difficult topics very smoothly and easily. I congratulate you and thank you very much.
Thank you. Dr. Hafizullah, as a cardiologist, we have seen CVD prevalences, we have seen the death rates because of diabetes, we have seen some results on HDL, HDL, hypertension. What do you feel about this? Now, we have the local data. We did have local data of South Asian population, PAK trial and that stuff. So what do you think about it now?
Yeah, thanks for having a foreigner over here. The cardiologist is like a foreigner in diabetologist, but we enjoyed the talk. First of all, we feel very envious of PES because I think you've done wonderful research. When we present a talk on hypertension, the data comes from the diabetes, and this data is absolutely fantastic. I would like to congratulate, and I feel very honored to be here listening to your talk. It was an absolutely wonderful talk. So this drug, SGLT, maybe it gets hijacked by the cardiologist, and maybe, diabetologists would probably like to use it, but we'll probably use it more and more. But beware of it. I mean, I was looking at the effects of it, Emperor study, and lots of it. It has got direct effects on heart. It reduces LV mass in people who have got a bigger mass by 6.1. It reduces end diastolic diameter indexed by 8 and systolic diameter by 6, and it improves outcomes. But this is happening in people who have got reduced ejection fraction. So heart failure with reduced ejection fraction. Please do not extrapolate it to people with preserved ejection fraction or mildly reduced ejection fraction. So I think we should not be unleashing the drug on every patient who has got an ECG abnormality or who complains of angina. This is in this set of drugs, and I think we see a very bright future of getting cardiologists and endocrinologists together, and let's work towards a better trial and looking for it, the effect of SGLT in hypertension, which it reduces by about 4 or 5 millimeter of mercury, but it will be wonderful to see it in a big data. Thank you very much.
Sir, thank you very much.